Thank you, Angela. And welcome, everyone. Good afternoon, and welcome to Chicago. And thank you for joining us from everywhere around the world, people who've flown thousands of miles to come here, and from all around the US. We really appreciate your being here. Chicago is great because it holds very special memories for not just for me, but for the Wiskott community, because this is where the first ever Wiskott conference was held in 2010, 14 years ago. 32 families came together. Dr. Ox was there too. And that was the start of the Wiskott-Aldrich Foundation, the way it is today. So it really, and the name of that, we called it New Horizons, New Hope. And that is what we hope to achieve for our community, having hope, having better treatments. So the Wiskott-Aldrich Foundation is a nonprofit organization run by volunteers. And our thrust is three things: research, education, and family support. The biggest one being research. So what do we want to do for research? We want to make sure we get better cures and improve the quality of life for our patients and families. And for people who attended Dr. Cohen's talk, gene therapy is the up-and-coming future. And as he said, the two biggest barriers are funding and regulation. And I'm happy to say that we are trying to address both. We are working closely with the FDA, not just to try to get the Milan trials here for gene therapy, but also to work on the US therapy getting forward. We're also happy to say that we're funding. We've funded one of the clinical trials. When I say fund, they cost millions. We do a small amount. But we have sponsored one of the trials, one of the studies, and also one study for gene editing, which is in progress in the UK. We also collaborate with other organizations, such as Amir Kheder from the Israeli WAS Association, who is organized a conference, is it November 18th, Amir? November 18th in Milan for researchers. So please talk to your physicians and let them know there's a research conference going on in Milan, and ask them to join us at that meeting. So education, we've been working with the IDF since 2010. Thank you to the IDF for collaborating with us every single event to bring such wonderful sessions to all of you with fantastic speakers like Dr. Ox and Dr. Pai, who are here for our families. Make sure you utilize this time. We don't get these times too often that you have these researchers fully at your attention. Please ask any questions you have of them and communicate with them. The third and last is the family support, which is sometimes the most important. We're always there for our families, making sure no family walks alone. We are there for anyone who reaches out to us, connect personally through our website, through our discussion group. And those are some of the things we do. And we appreciate each and every one of you being here. And I want to give a shout out to Amy McNally for being outstanding in helping put this WAS session together. Thank you, Amy. And with that, without any further ado, I'd like to introduce the speakers. Dr. Hans Ox, who needs no introduction to us. He has just been there forever and ever for us, working for decades on Wiskott-Aldrich syndrome. He's a walking encyclopedia of knowledge, a fountain of knowledge of Wiskott. For those of you who don't know, he is on the team that discovered the WAS gene in 1994. And he has diagnosed people like Mr. Facklum, who's 84 years old, and he diagnosed him. So he's been around forever, and he's always there to answer our questions. Anytime I send him an email, he will respond back no matter where the child is. He's always there for us. He is the Jeffrey Modell Chair at the Seattle Children's Hospital, Seattle Research Institute. And with that, let's give a warm welcome to Dr. Ox.
Thank you. Thank you. I don't believe it. So after the disclaimers, I just wanted to show you what Wiskott saw in 1935 and 36. He was a one-year-old boy with bruises. He had prolonged bleeding after circumcision if he would have been in the United States, but in Germany they didn't do that. But that's often a sign of a newborn who has Wiskott. He had bloody diarrhea shortly after birth. He had recurrent otitis, he had mucoid drainage, and he had eczema since the age of 3 months. And at that time, they didn't have steroid cream, but it would have responded to steroid cream. He had a negative family history. He had 2 healthy sisters. And then a definitive test was done in Munich, and I show you the test. They did a blood smear, and on the left side, you see a thick smear, you know, with a lot of white cells, and you see these bluish spots. These are the platelets of a patient. And on the right side, you see this blood smear from a normal control, and it was very thinned out. So you see very few red cells. But you see many of these blue spots, and they are big. And on the left side, most of them are small. There are occasionally a big one, and that's what the counter. I have to tell you, when we measure the size of platelets, we use a Coulter counter, and that system does not count the small ones. So actually, if a patient with Wiskott has 20,000, has many more small ones, which I call the platelet dust. Okay, let's go back to these two guys. So on the left side, that is Professor Wiskott, and I actually met him. He was retired. He was the chairman of pediatrics in Munich, and he discovered the syndrome, but he had no idea what the genetics were. So Aldrich came along, and he had a family from, when he was in Wisconsin, he had a family from Holland, and they had a clear pattern of X-linked. So he labeled it as X-linked. So that's why we call it Wiskott and Aldrich. So Aldrich published his data, and then somebody of the reviewers said, I think I have heard about this. There's a German guy who had a similar disease. And so they put it together, and it's Wiskott-Aldrich. And so that's what we now call Wiskott-Aldrich syndrome or X-linked thrombocytopenia. Those were two separate diseases before we had the gene. So it's X-linked inheritance. The thrombocytes are small and low in numbers, and most of them, if they are Wiskott or XLT, they have eczema. And then often bloody diarrhea, recurrent infections because of their immune deficiency, and then because of immune dysregulation, they can also develop autoimmunity and malignancies, usually EBV-induced malignancies. And the treatment can be symptomatic. That's what we did before we had hematopoietic stem cell transplantation or gene therapy. And gene therapy is sort of a little bit on hold, but it's certainly coming back. So everything has a history. That was Wiskott's original design in the medical records. Now we would have electronic records, and we wouldn't see that. So on the left side, there is kind A, that's child A, child B, child C, and then over the time, on top you see the dates. They had eczema, they had edema, they had colitis, they had bloody diarrhea, and at the right end, they all died, all three of them. And that was the fate of Wiskott-Aldrich syndrome. Between the first 2 years of life, they died because we had no antibiotics, we had no platelet transfusions, we had no antifungals, and we had no, of course, no hematopoietic stem cell transplantation. And that's, again, a design from Wiskott. And he showed here where the eczema was in his patients. The whole body sometimes, the extremities and even the trunk. And that's where he screwed up. You can see in the middle there are two males, and that's where his interest was. One was, there were two brothers, and they were healthy. And then he doesn't show the woman, but he married someone. Wiskott doesn't even show them, but then there were the offspring, and you can see the females. They were all okay, except one died early in life, which was not uncommon in 1935. But then there were three males who had the infection, and who had the Wiskott, at that time they called it actually morbus Verhoefi. And so, but he thought it was coming from the male. So that's why Aldrich was so important to call this X-linked. And matter of fact, Beloradsky, a colleague of mine from Munich, he studied offspring of this family, and he found that they indeed had mutations in the WASP gene. Now that was his first presentation at the German Pediatric Society in 1936. That's where he presented his data, and you can see here a whole bunch of speakers and talks, and if you go sort of in the lower third, there is Wiskott, München, familiärer, angeborener Morbus Welhofi. And he clearly said it's not ITP, because in Germany they called ITP Morbus Welhofi. And so he said it's congenital, and it has nothing to do with ITP, it's a new disease. And that's his prototype of a manuscript, you know. That's how he made his first manuscript and was then published, but you can see he was handwriting and hand typing. And then when the disease was known, I was a fellow, I had 4 patients who had Wiskott, and what I wanted to know is what their lymphocytes do. And I had a chance to test them when they were 2 years and 4 years, and their lymphocyte numbers were still normal. But then 3 of them, they dropped them. By the time they were 6, their lymphocytes really went lower and lower, and the immune system got weaker and weaker. But there's one, AS, he had actually the mild form. He had what we called XLT. He was a very nice guy. He was healthy. He got, actually they took his spleen out because they thought he had ITP. And after that, he got infections, one after the next, until we made the diagnosis and put him on prophylactic antibiotics. And when he was, and that is interesting, you know, he was XLT, but when he was 27, he developed leukemia. And he had a brother who was HLA matched, and they transplanted him in the adult service. He sailed through, went home for Thanksgiving to Alaska, and died of what? Of sepsis, pneumococcal sepsis, because the internist did not put him back on penicillin. So you can see XLT can have problems. And here, at that time, I did some chemotaxis, and I wanted to show you on the horizontal line, there is a time if you let them migrate, the white cells, the neutrophils, and on top these 100%, these little things here, they can actually show, yeah, here that is, show, yeah, that's a normal control, and after 60 minutes, the white cells of these patients did very poorly. They migrated maybe only 25%. And then, but over time, they caught up. And this top one is the XLT patient, who I told you who died subsequently, but he did much better than the others. And then we looked at 2 patients. We immunized them with a neoantigen, VIX-174. But this here is log scale, and you can see normal responses 3 times they were immunized, here and here and here, and they increased their titer. And here all is IgM, and then they can switch over to IgG. But look at these classic Wiskotts. They made 1% of normal, and then they drop back down to normal after 4 weeks. And then you immunize them again, and there's no expansion. There is no immunologic memory. And then we measured IgG, and they could not switch to IgG. And that's why they need IVIG or subcutaneous gamma globulin. And by the way, several XLAs, X-linked thrombocytopenia, XLTs, they made antibodies. They could isotype switch. So they are better off than those who have these more serious mutations. And I just wanted to give you a sense of this molecule, you know, stretched out. There are different domains, which we call. This one is important to put the protein on the membrane of the cell. This one, this GBD, is a binding site. I will tell you that if there is a mutation, then you don't have classic Wiskott, you don't have XLT, you have congenital neutropenia. And then there is the area, this is the area where the protein does what we call actin polymerization. That's important for the movement of the cells. You saw that the chemotaxis was problem. And here I show you, this is when the protein is inactive. It sort of folds itself in, and it cannot do its trick anymore. And there is a protein up here. If that is that has 3 phosphorus on it. If it becomes triphosphates, then it has a tendency to bind here and opens up the molecule. Now it's functional, and the end here that does this actin polymerization and moves the cells around, that is now active. So the protein is a protein that is inactive most of the time, and if it's needed, it opens up. And now, this is a pedigree of a gentleman who is right in our midst. And I made this before I talked to him today. So this was in the late 1990s, an astute pediatrician made diagnosis of this infant, less than a year of age, and we made the diagnosis. That's a mutation, it's an amino acid substitution at position 56. And then we said, well, let's see if the mother is a carrier, and she was a carrier. And then they said, our 59-year-old, now he's 83, our 59-year-old grandpa, he had bleeding all his life. So we tested him, and he was, we called it XLT, he had the same mutation as his grandchild. And then they came up and said, but there is a great-grandmother of this baby. She's 87 years old in a nursing home, and she was bleeding all the time. And so we studied her, and she also she was a carrier. But the difference between the 87-year-old and the mother of this baby, was that the mother had, you know about X chromosome inactivation. A woman has 2 X chromosomes, and one is slipped off, and the other one is used. And in most women, it's about 50-50, 60-40. So she had 60-40, and she had 90% of her X chromosomes were the abnormal one. She had only 10%. So she was actually an XLT, like her son and like her great-great-son. And now the story continues. There are 2 more generations also with XLT. And one of them, I think the youngest, has been successfully transplanted. There is a mother right there. So you can see that, and the 87, the now 83-year-old looks very healthy. He looks there, he's doing whatever he wants to do. So he is a lucky one with the XLT. And some of the XLTs are unlucky, like my patient. And so, how do we put this into a plan? Should we transplant all the XLT, or should we not? Should we call the XLT Wiskotts, or should we call them mild phenotype, or should we just call them historically XLT? That has to be decided. And this is a study, international study by Michael Alpert. We all were involved in it. And he looked at the overall survival of XL for X-linked thrombocytopenia, the mild ones, and it's the same life expectancy as the German population. But then when you look at, on the right side, event-free survival, you can see that by the age of 30 years, 50% had serious problems. Severe bleeding, severe infections, autoimmunity, malignancy, or death, especially if they were splenectomized. So that brings me to the issue of splenectomy in the mild cases. No, in the classic Wiskotts, we don't even think about splenectomy anymore because we transplant them. But if you take an XLT patient or mild Wiskott and you do splenectomy, their platelets increase better than if you do bone marrow transplantation or gene therapy. The rate of serious bleeding is significantly decreased of these 185 patients, where 40 had a splenectomy. But there was a significant increase in severe infections. That's the problem. And so they need to take, do I have to stop? Okay. So otherwise, there is no significant benefit from splenectomy. They still have all the other problems except the platelets. And here I want to show you, on top, the XLT, you see all these little round dots. Those are all missense mutation. And then on top here, this is invariable splice site mutations. They all had protein. And down here, the classic Wiskotts, those are the serious stop codons and this insertion and depletions. And so if you look at the patients we had at that time, about half of them were XLT, the other one were classic Wiskotts. And then there is another one, intermittent XLT phenotype. They do very well. They have no infections, except that sometimes on top, this is a normal range. On top, sometimes they are normal and sometimes they are abnormal. And we studied them together with Cicino Tarangelo. They all had a normal life expectancy and no serious infection. And I want to point out congenital X-linked neutropenia. That's the third clinical phenotype. And they have neutropenia at birth. They have a maturation arrest. They have infections classic for neutropenia. And they have no autoimmune disease, no malignancies, and there are also some family members with the same mutation. They are not symptomatic. And this, I should stop here. I just wanted to show you the scoring system, which goes to 5. And if you take the X-linked, the intermittent X-linked thrombocytopenia, which I have sometimes neutropenia, they just have thrombocytopenia and small platelets. But then you get in the XLT population, the mild Wiskotts, they are 1 and 2, and you know they have thrombocytopenia, small platelets, and sometimes some immune deficiency. And the classic Wiskotts, they are 3, 4, and 5. 5 is if they develop either autoimmune disease or malignancies. And that is our scoring system. A 0 is, there is no WAS or XLT findings. They have X-linked neutropenia. Score of less than 1, intermittent, this intermittent platelet problems. And then score 1 and 2 is the mild forms, and then the 3 to 4 are the classic WASPs. And what can we do? In the old days, without hematopoietic stem cell transplantation, we just made the diagnosis, tried to not do circumcision, treat their infections, and then, of course, you make the diagnosis. Now we can measure the protein or the gene mutation, and then, of course, we try to do genetic counseling to identify carriers. And then we Google it, what other options there is, and then you go for it. And I just wanted to tell something about platelets. Platelet transfusion is not a treatment for Wiskott-Aldrich. We use it successfully if they have a serious bleed, a GI bleed, a CNS bleed. Otherwise, I just wanted to point out, they get sensitized, and suddenly they develop ITP. Or they can subsequently reject a bone marrow transplantation. So only required for brain hemorrhage, severe GI bleed, or other bleedings that cannot be stopped, and just try to avoid it and give these kids a helmet. So splenectomy, you are damned if you do, and you are damned if you don't, maybe. So PRO increases markedly the number of platelets and protects from bleeding, but then I mentioned that they can have lethal sepsis with pneumococcal. And we will hear about transplant, more about it. You know, you need to have a donor and you need to have the patient in excellent state. And gene therapy, successful in both models, was successful in patients, but you know, we have a burden. And I just put my friend Christopher Klein, he's now in Munich, he transplanted 10 patients with the wrong vector. And of the 10, 1 rejected, 9 got, and all 9 developed leukemia. So, you know, gene therapy, rightfully, we have to be very careful. We have to work it out like Dr. Cohn. We have to have long-term follow-up, but it is certainly a very interesting and a treatment that will be very hopeful. And I wanted to show you this picture. That was his announcement of his 70th birthday. That is Wiskott. That's how I remember him. And that is Seattle in spring, when all the students, instead of being in the lecture halls, they are sitting under the cherry blossom trees. Thank you very much.